Welcome to AI Decoded, the time of the week when we look in depth at some of the most eye-catching stories in the world of artificial intelligence. And this week we looked at how AI is helping to revolutionise healthcare and how one scientist is helping to lead the charge. Well, MIT professor Dr. Regina Barzilay develops machine learning AI models to help predict breast and lung cancer. After discovering that she had breast cancer herself back in 2014, Dr. Barzilay decided to use her diagnosis to create new AI tools designed to try and save lives. A decade later, the AI model she and her team built, named Mirai, is now able to detect a patient's risk of developing breast cancer within 5 years. To date, Mirai has validated over 2 million mammograms in 48 hospitals across 22 countries, earning recognition from Time magazine for her as one of the top 100 most influential people in artificial intelligence. Well, with me in the studio is Hare, host of AI Decoded, and as previously mentioned, we are joined by Dr. Regina Barzilay, who is AI faculty lead at the MIT Jameel Clinic. Welcome to you both, and thank you, Dr. Barzilay, in particular, for being with us today. Can you just tell us, first of all, the moment that you found out that you had breast cancer, and then you realised that the answers you were looking for were not easily findable, how did that then lead to your developing this new model?
So first of all, great to be here, and it now sounds like a very old story, but at the time for me it was quite dramatic. Nobody in my family ever had cancer, or breast cancer in particular. So when I was diagnosed at age 43, it was really a shock. And the question that I was always asking myself is, what happened? I didn't think of myself ever as high risk because I don't follow a typical profile. I don't have BRCA genes and others. And then I realized that actually the vast majority of women who are diagnosed are first in their family and they don't have, genetic profile. So this was a point that only technology can help, because otherwise we don't really know who is going to get breast cancer. So once I went through my own treatment, I started thinking how we can change it. And I couldn't stop thinking how my life would be developed and that I have to lose my hair if I would have been diagnosed a few years earlier. In the US, we screen since age 40. So I went through several mammograms before I was diagnosed. So I wanted to have a tool that can take an image and tell us the risk of developing breast cancer. We did the same thing afterwards with lung cancer on CT scans. And that's how I ended up developing Mirai with a big team of students and colleagues.
I'm curious if you could talk us through, how does this allow you to predict somebody's likelihood of having breast cancer within 5 years? What data are you drawing on that's new?
So if you compare cancer to, let's say, infectious diseases, typically, once you get a virus, within a very short time, you would see symptoms, while diseases like cancer may take years until we will actually see the symptoms or feel them. So when the radiologist today diagnoses a patient with a cancer, it doesn't mean the cancer was not there in the previous image. It just means that it wasn't big enough for the human eye to see. So what we use to train these models is images with an outcome. So if you look at somebody who took their mammogram in 2020, you would know what happened to them in the next 5 years. So the machine is trained to say, if I give the image today, what's likely to happen in 5 years? And most likely what the machines are looking at are very subtle changes in the tissue that human eye cannot detect, but machine can if it is provided with the right type of supervision, which is the future outcomes.
And what was the process like of going from the model to it actually being used in clinical practice? I mean, are you pushing for it to be used in a more widespread way?
Yeah, so the first question is, how can you bring to the clinic a tool which radiologists cannot verify? The only thing that the radiologist can say, whether they see the cancer right now on the image, but Here you have a tool which can tell something to the doctor, which doctor cannot immediately verify. So one of the first steps for us to actually bring it to patients was to verify it in this huge, diverse population. And we went to various exotic locations, of course, US, and there is a big team in Cambridge, UK, that verified the verification of Mirai. But we went to places like India and Taiwan and many European countries and Latin America. The first thing was to ensure that the model sustained performance on diverse set of women. This gives us confidence that the model really works. And then the next question, actually again, the local team in UK is looking into it. How do you bring such a tool to the clinic? And the difference here is not only about bringing AI, but actually doing something distinct in the hospital. Now we are not using, mammogram to say who has cancer, but really to identify the future risks. And the second one is to personalize your screening regime. So it requires not only AI technology, but it requires changes in healthcare system that can accommodate it. So in different countries, teams of doctors are currently developing various protocols how to bring these kind of models and make them standards of screening.
And Dr. Barzilay, I should say my father is a radiologist and he's still working, and he actually just recently took part in a chest x-ray AI pilot experiment. And here in the UK, each hospital and trust is run differently. There are different protocols, even for one simple procedure, in terms of whether it's two radiologists screening, whether it would be an AI and then a doctor. That's not been rolled out yet. And I just wondered, the lack of consistency is a real issue, isn't it, across healthcare in many parts of the world? And therefore, if you kind of come up with an amazing tool, people might be asking, well, we all want access to these amazing tools.
So I think that the lack of consistency is really a great point that you just made. And I want to just give a reference to a study that we've done with a very big trial, in this case in lung cancer, that was done in the United States called NLST, National Lung Cancer Screening Trial. And what we've discovered that at least for one set of the patients, the patients were screened like every year, and we found that at least for one set of the patients, their cancer actually is seen by AI a year, sometimes 2 years earlier before the doctor saw them. So it means that one set of the participants in academic centers, had their cancer growing in them for several years, which is really unfortunate. So the goal here is really to create this equalizer that first of all will provide consistent readout no matter where you're gonna go and do your imaging, be it a mammogram, be it CT scan or MRI, and bring these tools really to the patients, because we know how to treat early cancers, but we still cannot really treat metastatic cancers. So the earlier we can identify the patients, better we all will be. And we again know that the survival today per country really depends on the screening. The earlier the system, identifies the cancer, the better the outcomes.
And Dr. Barzilay, are you optimistic that we might be able to see this type of progress, not just for breast cancer, but all forms of cancer? Could we see cancer becoming a disease that we can effectively, safely treat in the future?
I definitely think for many cancers, like for instance lung cancer is one of them, where with this kind of technology you would be able to identify who really needs to be screened, because of course we don't want to overscreen and send people for imaging when they don't have to have it. But also there are a lot of interesting developments on the in blood cancer screening and others. And again, the uncertainty that is inherent in these diagnostics, AI helps resolve. So I think this is, of course, my personal bet that within a few years, the stage of diagnosis across many cancer will come much earlier than we are having today.
And one area that comes up in debate around AI in healthcare is worries about who's responsible if something goes wrong once you start using AI tools. Is it the clinician? Is it the hospital? Is it the developer? Is it those who've kind of come up with the models and have or done the contracts? Did you have in terms of the legal jurisdiction, I suppose. How is that resolved for your cases?
So I think that this is really a big and open question, and clearly people are very much concerned, and that's why I'm suggesting that this tool shouldn't substitute the doctor. Ultimately, it is a doctor's decision what is the right step. And when these tools are brought to a specific clinical system, there should be all the safeguards in place to ensure that, weird things do not happen. But I just want to remind you and listeners that, one of the biggest causes of death, I think it's number 3, is doctor's error. So we're not talking about bringing AI to the perfect world where everything is perfect. We're just thinking, can we bring this technology to make our doctors a bit more, effective and help to bring the consistencies that today the clinical care lacks?
And is it, Stephanie, perhaps I can ask you as well, both to explain this. In terms of how this earlier screening works, it's about spotting signs earlier. Is this to do with pattern recognition? Can you explain, Stephanie, why these techniques are working in simple terms?
Well, I can try to. We'll also leave this to the professional doctor. In terms of the data itself, with any patient, early detection is key. So in breast cancer, here in the United Kingdom, for instance, we only start screening women from the age of 50. In the United States, it's more common to start at 40. So if you think about that, that's 10 years worth of data that's different. And as our guest was just describing, a lot of people will have cancer growing without realizing it. So you want to get in early. It's also something that sometimes machines are better at literally seeing. The way a machine sees and recognizes a tumor would be different from the human eye. They can potentially spot it earlier. So the best pairing is to have the human doctor working with AI with the earliest data sets possible.
Yes, and as you were saying, Dr. Barzilay, it's not about replacing doctors, is it? It's about augmenting their work, as the jargon